Everyone, and thank you for coming today. I'm Will Snell, Chief Executive of the Fairness Foundation, and it's my great pleasure to host this event focused on Professor Sir Michael Marmot's brilliant book, The Health Gap, The Challenge of an Unequal World. This talk is the second in a series of online talks called The Fair Society, which we're running in partnership with the Policy Institute at King's College London, and which explores issues of inequality, meritocracy, and mobility in the UK. The first talk in November featured Professor Michael Sandel and a panel talking about meritocracy. The Policy Institute, led by Professor Bobby Duffy, works to solve society's challenges with evidence and expertise. They have 7 main research areas, and inequality is a core theme. They recently published work on public attitudes to inequality as part of the IFS Deaton Review. The Fairness Foundation launched 2 months ago with the aim of changing the terms of the debate about fairness in the UK. Our launch publication, The Fair Necessities, outlined our vision of a fair society and our proposed 5 foundations of fairness, and you can read more about us at fairnessfoundation.com. So, on with the agenda. Sir Michael Marmot needs very little introduction, but here are some quick highlights. He is Professor of Epidemiology at University College London, Director of the UCL Institute of Health Equity, and past President of the World Medical Association. He has been awarded honorary doctorates from 18 universities, and last year received BMJ's Outstanding Contribution to Health Award. He has led research groups on health inequalities for over 40 years, and conducted the strategic review of health inequalities in England, which published its report Fair Society, Healthy Lives, the Marmot Review, in 2010. His book, The Health Gap, was published in 2015, arguing that people at relative social disadvantage suffer health disadvantage and shorter lives, and so that we need to address social inequalities to improve health outcomes. In 2020, he published the Marmot Review 10 Years On and Build Back Fairer, the COVID-19 Marmot Review. These reports revealed how the health gap has grown between wealthy and deprived areas of the UK, and how inequalities in social and economic conditions before the pandemic contributed to the high and unequal death toll from COVID-19. We have a brilliant panel to discuss some of the themes after we've heard from Michael, although I'm sorry that it's not as gender balanced as we had originally hoped. We'll be talking today about why it's more urgent than ever that we tackle inequalities in order to improve health, why more progress has not been made in the last decade, and how we can rectify this failure in the era of levelling up. The panelists are Joe Bibby, Director of Health at the Health Foundation. Joe has worked in healthcare at local and national level for 25 years, including 10 years at the Department of Health, and leads the Foundation's Healthy Lives strategy to create opportunities for everyone to lead a healthy life. Chris Thomas, Senior Research Fellow for Health at the Institute for Public Policy Research, IPPR, and author of a book published today called The 5 Health Frontiers, a New Radical Blueprint. Chris's research focuses on progressive solutions to the challenges faced by our health and care system. Jabir Butt is Chief Executive of the Race Equality Foundation. He has an international reputation for the use of evidence in developing interventions that help overcome discrimination and disadvantage. His studies have been used to inform government thinking, including interventions such as Sure Start. And finally, Professor Richard Trembath, Senior Vice President for Health and Life Sciences at King's College London and Executive Director of King's Health Partners. A geneticist by background, he works across the university to draw on its strengths and ambitions in contributing to local, national, and global health improvement through its research, education, and training activities. There should be plenty of time for questions after each of the panelists has spoken, so please put them into the Q&A box as soon as they occur to you, and I'll crack on and invite Michael to open, please. Thank you.
Thank you. I'm going to start by demonstrating that I'm not a politician. I'm going to offer a disclaimer and almost a note of apology. I published The Health Gap in 2015, and I agree with what I said then. That feels like it's something to be ashamed of. Have I learned nothing in the last 6.5 years? Well, actually, I've learned a great deal, and I'll talk a little bit about that. But I think the analysis that I tried to capture in the health gap still stands. The opening line of the book was, why treat people and send them back to the conditions that made them sick? Particularly at the time of a pandemic, we think a great deal about the healthcare system. We hear daily about the NHS overstretched, overcapacity, and it's absolutely vital that we have a proper functioning healthcare system. But inequalities in health are not due, by and large, to lack of access to quality health care, but to the social determinants of health, the conditions in society that make people sick in the first place. And what I do in the health gap is bring two types of inequalities together, those within countries and those between countries. Within countries, dealing particularly with socioeconomic differences, there is a social gradient. You've heard a great deal about the magnitude of it. I don't deal with it in the health gap in this example, but Grenfell Tower, in the area around Grenfell, compared with the richest part of the Royal Borough of Kensington and Chelsea, there's a 16-year gap in male life expectancy within that borough. So huge inequalities within countries and within local areas within countries, and huge inequalities between countries. And I go through the explanations for that. We define social determinants of health as the conditions in which people are born, grow, live, work, and age, and inequities in power, money, and resources that give rise to those conditions of daily life. And we need to function at both levels, looking at inequities in the conditions of daily life and in power, money, and resources. One particular issue, and Will mentioned it in the discussion, that I deal with at some length in the health gap, is the question of absolute inequality or relative inequality. In our most recent report, Build Back Fairer in the Eastern Mediterranean region of WHO, which we published in 2021, and a couple of years before that, the commission which I led on equity and health inequalities in the Americas for the Pan American Health Organization, we adopted the phrase that we used in Europe: do something, do more, do better. For people in absolute poverty, do something. Absolute poverty really matters. If you haven't got enough to eat, if you can't heat your dwelling in a rich country like Britain, that absolute deprivation will damage your health. There's nothing relative about that. It's absolute. And certainly in middle income and low income countries, destitution really matters. Do something. But above that basic level, relative differences matter a great deal more. And let me illustrate, and I use this illustration in the health gap. I talked about the inequalities in London. I use the example in the health gap of the US city of Baltimore. In the poorest part of Baltimore, life expectancy for men is 62, and in the richest part, it's 77, 78. Family income in the poorest part of Baltimore in 2010 was $17,000. $17,000 is the average income for Costa Rica, adjusting for purchasing power. So it's equivalent to purchasing power in Baltimore. And yet life expectancy in Costa Rica is 15 years longer than in the poor part of Baltimore. this is not absolute deprivation in the normal sense that we're talking about, because after all, we've adjusted for purchasing power. And yet the poor people of Baltimore have much dimmer prospects for health and life expectancy than the average in Costa Rica. And I resolve this conundrum by appealing to Amartya Sen and the idea that relative inequalities with respect to income lead to absolute inequalities with respect to capabilities. It's not so much what you have, but what you can do with what you have. And that's crucially dependent on our social arrangements. So being poor in the poor part of Baltimore is really bad for your health because the housing just doesn't match up to the housing elsewhere, because young people get into all kinds of strife. The chance of being arrested for some juvenile disorder is 1/3 each year, 1/3 each year. The chance of getting to age 18 without an arrest is really quite slim in the poor part of Baltimore, and that damages young people for the rest of their lives. So absolute relative inequalities with respect to income lead to absolute inequalities with respect to capabilities of what you can do with what you have. One young member of my extended family asked me, "Is anyone listening to you?" And I thought, this young chap has got a bright future ahead of him. He knows the right question to ask. It was a good question. Is anyone listening to you? And my evidence-based answer is yes, they are. We'll refer to our report, Health Equity in England, the Marmot Review 10 years on, which we did with the Health Foundation. And that was really shocking. That was really shocking. We're used to health getting better all the time. And rightly so. And the improvement in health slowed dramatically. The inequalities in health got bigger. And life expectancy for people in the most deprived 10% of areas outside London went down. People got sicker. That decade from 2010 to 2020 was a disaster. And I don't think it's because we got the analysis wrong in my 2010 review. I think we got it right. In fact, it provides an explanation for why things went so badly. Because government policies of austerity led to a rise in child poverty, a decrease in spending per person on education, a regressive settlement for local government. The poorer the area, the bigger the reduction. If you go across our recommendations, almost all of them went in the wrong direction. And that was before the pandemic. And then the pandemic came and exposed the underlying inequalities in society and amplified them. And in fact, the analysis that I write about in the health gap for the social gradient in health applies to COVID-19. It's a virus. And yet, if you classify people by level of deprivation of where they live, you see the social gradient. The social gradient in mortality from COVID-19 looks almost identical to the social gradient in mortality from all causes. So yes, we have to control the virus, but we have to deal with the underlying social inequalities in society, which is why I called 4 reports from December 2020 to last year. 4 reports I gave the title Build Back Fairer. In England, in Greater Manchester, in the Eastern Mediterranean region of WHO, and in Hong Kong. It means we need action at the supranational level, at the national level, Hong Kong is a jurisdiction within a bigger country, or at the regional and city level, Greater Manchester. And that action needs to be on what we call the causes of the causes, the social determinants of health. If we create a fairer society, health will improve and health inequalities will diminish. What more important task could there be before us? Thank you, Will.
Thank you, Michael, for setting the scene so brilliantly. I'm going to hand straight over now to Joe to kick off the discussion about why we haven't made more progress on this agenda to date and hopefully what we can do about it. Thanks, Joe.
Yeah, well, thanks very much, Will, and privileged to follow Michael in this discussion. So for those of you that haven't come across our work, the Health Foundation, just to say we're a endowed charity, and we fund research, policy analysis and practice development to improve health and health equity. And we've been working on this agenda of health and health inequalities for the past 5 years. We've supported work that Michael and the Institute for Health Equity have done, and a range of other activities. And if you go to our website, you can find evidence and resources to support action. But I think in doing all the work we've done, there's one question that I kind of constantly come back to, which is why, given all the evidence available on the extent and the causes of health inequalities, and given the various points in time at which people have marshaled this evidence very effectively over the past 40 years, why hasn't more been done? And we think to answer this, we need to start thinking about the public's understanding and their attitudes to health inequality. So kind of really great to see an organisation like the Fairness Foundation taking this on, because if health inequalities aren't a public priority, they won't be a political priority. And we've been doing various bits of evidence gathering. We've been doing polling and ethnographic work and focus groups and so on to try and understand what the public think. And we've looked at what others have done, including the really excellent work that Bobby Duffy at King's has been doing. And from this, we've started to distill some insights on this question. And what we're finding is we think it largely comes down to how we communicate the evidence to the public and how we can frame it in the context of their starting point rather than just the vantage point of the expert. So I'm just going to take the next few minutes to share some of these insights. So first, when we've done work with the public, what we've found is that actually is a much more limited awareness of the extent of inequalities in people's health across the UK than you might think, particularly when, it's your day job and you spend time thinking about this all the time. And we find that when we present the data, though, people are very shocked. So that's kind of a positive. People are shocked and surprised at the extent of the inequalities. But actually, sometimes so that the first thing is to start questioning the data. But second, once people do kind of, they accept and they're aware of the extent of the inequalities, we see a pattern of response, one of two ways. So some people look at it and they look for individual solutions. They see it as a consequence of people making bad choices, of not having the right information. Very often they think it's a problem with the NHS rather than the wider factors. And in fact, so much so last year at an event, like this, someone asked me, how can poverty make you ill when the NHS is free? So I think this really points to a fundamental disconnect between what we know the evidence tells us about what makes us healthy and how many people across the country think about this problem. What we find when people do understand and kind of start to think about the wider determinants is that actually a lot of people can become overwhelmed with the size of the challenge. They find it hard to see what can be done. And this can actually then tip their response into one of fatalism. So essentially the view that life isn't fair and this is just one more proof point. So I think, this combination of lack of awareness of the extent of health inequalities and that lack of understanding about what can be done can mean that the public don't prioritise the need for action on health inequalities. And I think this was very visibly shown by the work that Bobby Duffy did, I think it was published last year, as part of the Deaton review, where they found that, around 60% of respondents cited inequalities between deprived and well-off areas or inequalities in income and wealth as being a top cause of concern, whereas only around 20% cited health inequalities as a top cause of concern. Now, obviously, we know that the two are related, but I think the issue is that if the public aren't seeing those, seeing the problem as being one of unequal outcomes in health that those wider inequalities create, then the policy responses may not maximise the benefit for those with the lowest life expectancy. So the third problem we've identified is that the type of language that is often used to talk about health inequalities doesn't necessarily kind of land and relate to the people who are most affected. Most people, even when they face serious hardship, don't necessarily see themselves as being deprived, kind of being the people that we're talking about, because actually maybe they know someone worse off than them. Maybe they have other things in their lives that enrich them, their family, their community. And clearly, undoubtedly, people are very resourceful in order to cope with the kind of uncertainty life throws at them. So there is a big challenge about the language that experts are using, and actually the need to place their analysis in the context of the lives of people who live with these challenges. So taken together, I think this points to this gulf between the people who are communicating about health inequalities and the public that they want to engage. And so one of the things the Health Foundation has been doing is working with an organisation called the Frameworks Institute to look at how we can develop new and hopefully more effective framings that will engage the public. And findings from this work will be published in March. So in conclusion, I think to get the policy change needed to close the health gap, we need the politicians to act. For the politicians to act, they need to know that the public are concerned. And if we want the public to name health inequalities as a concern, we need to start communicating more effectively. So thanks for a chance for sort of sharing that perspective, and I look forward to further comments and the discussion.
Fantastic. Thank you, Jo. I'm going to hand straight over to Chris to give his thoughts on the same question.
Thanks, Will, and I'll just echo Jo that it's a privilege to be speaking here. For those that haven't come across IPPR, I'll give the quick spiel, but we're the country's largest progressive think tank, and we're based in London, Manchester, Newcastle, Bristol, and Cardiff at the moment. So we like to think of ourselves as genuinely across the UK. And I wanted to take, I suppose, a very similar question to Jo's, really, which is, why has it been so difficult to see change happen and to achieve progress on health inequalities, despite the fact that actually some of the conditions that we'd normally associate with change seem to be in place? And I think if you were to look at it coming completely fresh, you might identify two reasons why change could happen. The first is the sheer quantity of evidence. So we've got that vital causal link that Michael's work has developed, both in terms of the fact that health inequalities exist, but also why they exist and that link to the social determinants. And then also ever more so the consequences. So the cost of health inequalities and what they mean for macroeconomic indicators like productivity or for just wealth inequality as well. So that's the first. And I think the second that you think was a condition for change and is often talked about as a condition for change, whether that's in Friedman or Marx or Kingdon or whatever it might be, is crisis. So we have a moment of severe health crisis, and one that has, in the shape of COVID-19, only been fueled by health inequalities, and has impacted people that were already, kind of feeling the consequences of health inequalities the worst by far. And yet we have equally a situation where it doesn't feel, and I don't know if others will agree, that the status quo looks particularly likely to change. And a really interesting case study of that is the health and social care levy, insofar as we've seen, and of course, reiterating Michael's point, it's important to have a functioning health service, but we saw money allocated to the NHS just 1 week after the UC uplift of £20 a week was cut, and as we head into a cost of living crisis. So I suppose this kind of understanding of the broad definition of health doesn't necessarily feel like it's taking off as a consequence of the crisis we've just faced. The lessons of COVID-19 at a political level don't necessarily look like they've been learned. So in answer to that, and thinking about, well, it still feels like that window of opportunity for change is open, the work of IPPR has been really focused on thinking about what are the things that we need to secure that change. One of those is definitely public perception. So I won't retread the ground that Joe's already covered so brilliantly. But there are two more that I think are important to throw into the conversation. So one is really the structure of the ecosystem that exists around health inequality. And in a piece of research that we did at the end of last year called Making Change with Runnymede, our question was really looking at some movements where there's been great success and progress, and looking at some movements where success and progress has been harder to achieve. What are some of the differences that we can identify? And the structure of the ecosystem was a really important one. If we're thinking about, say, if we contrast the LGBTQ plus movements of the second half of the last century, or the climate change movement that we see having success and cut through, particularly in the United States today. And in particular, we categorize that ecosystem as made up of 4 categories. So 3 of them very strong in health, and those are helpers, so people that help provide service delivery that directly combats the problem of inequality. Organizers that provide the coalitions and organization we need to drive change. Reformers, many of which are on the call in terms of think tanks and researchers, people that have the ideas and create the evidence. And then one that we're particularly weak, so rebels. And if we compare the climate movement very directly to the health inequalities movement today, we don't have the equivalent, if not really, of the Greenpeaces, the Extinction Rebellions, Fridays for the Future, Green New Deal Rising, organizations that I think, and we were surprised in some ways by this finding, but those are the organizations that create a link between the evidence that we're talking about and the public appetite and the public salience for change. So that conduit, that really vital conduit, was something that in this piece of research came out as missing. The second thing that's quite interesting is the nature of the policy asks that we have on health inequalities and the socioeconomic determinants of health. And I suppose if we think about the kind of evidence and the kind of asks that lords out of that, we have in some ways brilliant policy asks, but in silos. So we know on, say, an issue like housing, an issue like child poverty, we know what some of the evidence-based solutions look like, and that work has been developed really well in an evidence-based fashion. But perhaps what we lack in terms of taking the case to people, and again, that conduit to public perceptions, it's genuinely totemic asks. And if we look at the movements that emerged out of the 2008 financial crash, the New Economy movement and the Green New Deal, both of those were organized around a totemic policy that encompassed a lot of the detail. It didn't necessarily sacrifice the detail, but which spoke very clearly to the kind of fundamental changes that society needed at that kind of very macro level to embody the change that needed to happen. So I suppose thinking about the conversation, the people that we have in the room here, there are 2 things to reflect on. It's that it feels like the opportunity is definitely there, that we have the evidence and we have the moment of opportunity that we need. But there are a couple of things that we can pinpoint as missing for us. That would be the rebels and the totemic cut through of the policy asks that we have. And that ties in, I think, to the conduit that we need to people and to the cut through that we need with politicians for change as well. So I will leave those reflections there because that's probably enough for 6 minutes, but really interested to get to the discussion and the questions as well.
That's really great. Thank you, Chris. I will hand over straight to Jabir.
Thank you, Will. The temptation following Joe and Chris is to say ditto and leave it at that, but perhaps I'll expand a little. Potentially, the answer as to why there's been so little change is racism, and I don't want to get away from that as a potential answer. Everyone's right, and Professor Marmot has been one of the individuals who's led some of this work, that we have improved the quality of evidence over the last 15, 20 years. Certainly, Acheson's study from whenever back it was in 1999 was a major step forward in recognition around Black, Asian and minority ethnic communities' experience of health inequalities and the need to address that. But it had actually been the case that the exploration of the evidence has been variable over the years. Some attention has been paid to it, and at other times it's been ignored entirely and seen as not being there. Clearly, there's been failings on organizations such as ours as well, that we've sometimes, in presentation of our evidence, we've developed a victimology, suggesting that it's so bad for Black, Asian and minority ethnic communities, and that they're just the victims of a system that's not going to allow them to have any control over their lives. And that's been an error that's been demonstrated by a range of issues. The incredible improvement in educational attainment in London since the year 2000 has had a real and material impact on Black, Asian and minority ethnic children's lives. It clearly has played a part. We may still be arguing about why that has happened, but there has been a clear change and an identifiable change. The fact that the rise in working age population since 2003, the majority of that is from Black, Asian and minority ethnic communities, is also a really important change. Something like we've moved from about 1.7 million people from those communities in the workforce to 3.7 million in that period, and it's a significant change. But what's also clear is that racism continues to have an impact on the lives of Black, Asian and minority ethnic communities. That improvement in employment over that period of time has been accompanied by greater likelihood of being in insecure work and poorly paid work as well. So a key driver out of the experience of deprivation still is actually embedding that experience of inequality in Black, Asian and minority ethnic communities' experience. And unfortunately, COVID-19 has just demonstrated that in spades. We published a briefing paper on March the 28th, 2020, that highlighted the greater risk that Black, Asian and minority ethnic communities faced, including Black, Asian and minority ethnic workers in health and care faced. Little attention was paid to that. It certainly wasn't picked up by the press. More worryingly, it wasn't picked up by our colleagues in health and care either. It's not until the dead bodies started to appear towards the end of April that we got real attention. It's not until The Guardian started to publish the pictures of healthcare workers that had passed away that we saw the NHS and other leaders start to pay attention to this. It shouldn't have been the case that we waited that long for that action. Why is the biggest employer in the world waiting until the end of May 2020 before it issues guidance on risk assessment? Where were the regulators? Where are the regulators today? What was the HRC doing? What was the Care Quality Commission doing? What was the Health and Safety Executive doing? They were all part of the system that should have protected those communities better and appear not to have done so. But I have to be honest, it all comes down to politics. The Sewell report is just the latest demonstration that we've not been able to persuade politicians that addressing racial inequality is something that is a significant and urgent action to be taken. What we've seen instead is prevarication and an attempt through the Sewell report to actually deny the experience of that racism. And I really do think that a session such as this, as well as others, while we will be calling out the need for, we're calling for the need for change, the reality is that until we're able to influence those politicians, we're still going to suffer the same consequences, and our communities will continue to experience inequality at the level that we're increasingly seeing. Thank you very much.
Thank you very much, Jabir. I'm finally going to hand over to Richard Trenworth.
Thank you so very much. My own thanks for the opportunity to join this panel. Well, as Will, if I can remind you, because it's a little while now since he gave the broader introduction, I come to this really as somebody that oversees and holds a mission of the integration of broader clinical health service delivery with an academic underpinning through what is called an academic health science centre. We call ours King's Health Partners, and that integrates the activities and ambitions and aims of 3 healthcare providers, 3 very, very large NHS trusts. 2 of them are acute, and one of them is one of the largest mental health trusts. And that, of course, is a really important intersection, and I think is also relevant to our broader discussion. And that the King's Health Partners allows us to align alongside a multi-faculty university. And of course, that is also critical here, and something I think is of relevance to how we think to the future, because historically, we have really focused our efforts around education, training, and research through rather traditional alignment of so-called health faculties, medicine, dentistry, nursing, midwifery, and the like, and perhaps have been incredibly slow to bring in the wider dimensions of academic engagement into this. And I think, of course, what sits at the very heart of this discussion is traditional health approaches are not going to address the challenge. So of course, the other challenge that I find on a regular basis, and I've spent a significant amount of today in discussion with our partners, is actually sits very much even at the nomenclature. So I've described the trust that I work with. They are part of this great national health service, but of course they historically and even now were established to alleviate the ailments of the sick. And what, of course, we're seeking to address here is interventions that, of course, preclude the genesis of ill health. And so even the nomenclature probably is unhelpful in and of itself. And if anything, of course, over the period that we're describing, these major trusts have intensified their approach, innovations driving greater opportunities to intervene in advanced stages of disease, but of course in no way does that address the central tenor of the question before us this afternoon, where of course these major healthcare providers are seeking to go. And part of this, the driver here, I will freely admit, is almost certainly not because this is a recognition of health inequalities. It's the no longer sustainable approach to healthcare delivery. It is to seek to be very much more targeted in the interventions that are made, and for those interventions to come much earlier in a disease process. As I have said, those in and of themselves, of course, are and will not address the inequalities. Actually, I think there is a significant risk they may exacerbate, because, of course, they will require equity of access to such interventions. And I'll example that in a few moments, if I may. Jabir, I think, has made some pretty profound and important points, and as somebody working within the major acute health trusts, I'm afraid I still retain with some pain the agony of seeing and recognizing in those very early days the demographic, if I may use that term, of those who were requiring intensive care was very stark and profound. And we have seen that, of course, continue over this last period of time. Did we need a pandemic for that demonstration? Of course, the answer is no, but it has made it very, very much central to our thinking. We have developed incredible tools, and Sir Michael has, of course, utilized these Indeed, we have increasingly sophisticated tools for using our data analytics to describe the challenge and to monitor it. And of course, the issue is where and how are we going to bring these interventions into play? I've made reference to this within the context of health delivery about a much more targeted approach for very much earlier interventions. These only represent, of course, the later stages of what is required. Will did mention it, my own area of expertise, I'm a geneticist, and of course, in the balance of the contributions to health inequalities, I'm certainly in no way describing that genetics is a contributor to this. But I would also add, we have this great ability to go on compounding the challenge. We hold great hope through genetics that we can harness that to get a better sense of who would benefit most from specific and targeted interventions. We've done a huge amount of work globally in trying to understand this. However, the application of those is compounded because most of the work that has gone on, by far, has been in populations predominantly of European heritage. Their applications will be and are necessarily different across different racial groupings. And we need to recognize there was a grave risk if we took an approach that used, for example, genetics to help in that approach to targeting interventions will, if anything, only exacerbate the opportunities for health inequalities. So with that, I don't offer great advice as to, or indeed opinion as to how we will tackle the problem. What I would say is for a health system in the one I've described to you, we increasingly, of course, are now working with, and this might sound ironic that it's taken this long to do so, but increasingly with our local authorities. And the logic there, of course, is that we do have significant lobbying power, but the drivers are compounded here because the resources, and I'm sure we're going to get to this, that sit within the necessity to maintain the health systems that Sir Michael quite rightly described are important and necessary, are probably the very resources that will end up being distracted into addressing some of the issues that lie at the very heart of the challenge. So with that, Will, may I hand back to you for opening this to a broader discussion.
Thanks very much, Richard. And thank you to all the discussants for their views on why more progress has not yet been made. Michael, I'd like to invite you, if you'd like to spend a few minutes just responding to what you've heard so far. We've heard about public attitudes, the type of activism on social determinants, the lack of totemic policy asks, the effects of structural racism and of systemic constraints within delivery of healthcare. So just be very interested in your reflections on those points.
Yeah, well, firstly, thank you to all four brilliant comments. And I was taking notes, and I'd like to make 5 points based on what I heard. The first is Joe reported that people find it overwhelming once they recognize there's a link between society and health. They think it's overwhelming. And yeah, I hear that commonly, which is why we had 6 discrete recommendations in Fair Society, Healthy Lives: early child development, education and lifelong learning; 3rd, employment and working conditions; 4th, having enough money for a healthy life; 5th, healthy and sustainable places in which to live and work; and 6th, taking a social determinants approach to prevention and lifestyle. So they're tangible. We take this complex, big deal, and we break it down into discrete parts, and we can tell you what to do in each of those. You can reduce child poverty. We know the Chancellor took a decision one Wednesday to increase child poverty by 300,000 between Wednesday and Thursday by cancelling the upgrade to universal credit. He could, were he so minded, between Thursday and Friday, take 500,000 children out of poverty. He could do it. So it's discrete. There's a policy available that could be done overnight. The second relates to racism. I touch on it in the health gap, but a part of the learning that I went through after the health gap, I wrote the health gap, particularly in our Commission on Equity in Health and Equalities in the Americas. We talked about structural racism. We talked about colonialism, the persistent effect of colonialism. And that's a key driver. There's a lot of discussion, particularly in the United States, of the degree to which you can explain the health disadvantage in the US context of African Americans or indigenous Americans by socioeconomic characteristics. And for a long time, I thought you could. My commissioners in our American review educated me and said, there's something else going on. You've got to deal with racism. And so I think of racism, structural racism in relation to health inequalities in two ways. One is that it conditions the exposure to those 6 domains that I talked about. It means that if you belong to certain ethnic groups, you're more likely to have child poverty, poor access to education, and so on. But the second is racism per se has adverse consequences, not just because it conditions exposure to those outcomes. The third point, it relates to what have we learned from the pandemic. We were told in 2010 that austerity was a moral imperative. We've got to get the public finances in order. It's a moral imperative. We've got no alternative. It turns out that was complete and utter bullshit. It was a political choice. It was not a moral imperative. And how did we know that? Because when the pandemic happened, the Chancellor of the Exchequer didn't say it's a moral imperative not to rack up debt. He said, whatever it takes, whatever it takes. I've just reviewed Adam Tooze's book for The Lancet, if you want to read it tomorrow in The Lancet. He pointed out that the rich countries in 2020 issued $18 trillion of new debt. So they didn't say austerity is a moral choice. They said, we'll issue. And what happened to that debt? Turns out half the debt was bought up by the central banks. I think it's called a conjuring trick. One branch of government issues the debt and another branch of government buys it up, and somehow that cures the global financial system. Wow. Well, it seems that's how it works. But as Adam Tooze points out, he said, on the one hand, neoliberalism ended. On the other hand, this settlement actually cemented all the pre-existing inequalities, didn't change them at all. So these are political choices. It's not that we can't spend money. Remember Keynes's dictum, we can afford to do anything we can do. We've got it wrong. We can't say we can't reduce child poverty because we can't afford it. If we can reduce child poverty, we can afford it. Clear lesson. The fourth, and Chris made this point, we should think about climate change and health inequalities in two ways. And I think Chris touched on both of them. One is, what do we learn from the climate movement that relates to inequalities? When are we going to have a COP1 for health inequalities? We've had 26 of them for climate change, and we're still wringing our hands. And when are we going to have a COP1 for global inequalities? And what would it take Would it take rioters in Seattle and Genoa? And remember, if you've got a memory of people taking to the streets in those cities, what would it take? And that's the rebel side of what you said, Chris. So one is the analogy, but the second is we've got to deal with these two global issues together at the same time, global inequalities and the climate crisis. Because if we don't deal with them together, it may well be the steps we take to deal with the climate crisis will increase inequalities. My fifth point relates to what Richard said. When I was president of the World Medical Association, we produced a report on what doctors can do. And it relates to what health systems can do on addressing social determinants of health. And we said 5 things: education and training, doctors, nurses, administrators and the like, in the social determinants of health. So people working in the healthcare system understand the link between social conditions and ill health, understand the relation between racism and ill health, that the education and training. The second is seeing the patient in a broader perspective. The third, we said initially the health care system as employer. I would now say as employer and anchor institution. The fourth is working in partnership. And the fifth, which I think you touched on, is advocacy. We care about health, those of us in the health sector. We're trusted for good reasons because we tell the truth. And people know that we tell the truth, so we're trusted to speak up about these things. So all 5 of those. And in other words, we need the healthcare system not just to treat people when they get sick, but to be active in addressing the social determinants of health, to be agents of change for health equity. Will.
Great, thank you, Michael. I'm going to ask now some questions from the audience, some submitted in advance and some submitted just now, and I'll invite whoever wants to respond rather than going through each in turn. But I'll come back to each of you for some closing thoughts. And I wanted to give you advance warning of a question I'm going to ask each of you at the end so you can think about it over the next 20 minutes, which is as follows. Congratulations, you've been elected to hold the office of Prime Minister of the UK, which is a post that may become vacant sooner rather than later. With your newfound power, what is the first act or policy that you would implement to improve health, life expectancy, quality of life, or health outcomes, or to reduce health inequalities, if you like? So I'm just going to give you advance warning of me asking each of you that question as a closing thought. Moving on to the questions elsewhere, a question around levelling up. Do you believe that the current political focus on levelling up signals a shift in political will to address inequalities, of which health is the most important? And the new Secretary of State for Health talks a lot about health inequalities and ethnic health inequalities in particular. How can we pounce on those to shift political will and lead to action? And a slight addition to that question from me, which is around the language of health disparities and the apparent focus that implies, at least in my head, on individual responsibility as opposed to addressing structural barriers, and whether that is a potential complication in terms of seizing upon this sense of momentum. Who'd like to take that one first? Joe, then Michael.
Yeah, thank you. Yeah, I think certainly there's an opportunity there. And I think what we need to ensure is that the Levelling Up white paper, both when it thinks about creating employment opportunities, when it thinks about improving transport infrastructure and all the things that we've seen trailed, that they think about how they do that in a way that reaches the communities that currently experience the poorest health. Because if that investment just kind of goes into leafy suburbs of parts of the country where, compared to the southeast, they may be disadvantaged, but they're not the worst parts of those areas in terms of life expectancy, then it's not going to reach the right people. So I think there's something about making sure that all that investment really does have the focus on improving healthy life expectancy and the life expectancy at its heart. I think one of the things, given that we know it's going to have a strong focus on employment, is there's, I think, a big issue around employment and mental health. We know that poor mental health and well-being is one of the biggest reasons why people are absent from work, why they're not able to get back into work. And unless we actually have strategies in place that can support people with poor mental health today, however many jobs we create in the right places, if the people who, want to be in those jobs aren't able to be because there aren't either the right support in the organisations they're going to work in or the right support to get them in those jobs in the first place, then we just won't see the benefit. So I think, yes, definitely opportunity, but it has to be done in a very thoughtful way to make sure it has impact on life expectancy and healthy life expectancy.
Thanks, Jo. Michael?
The report that we did for Greater Manchester, Build Back Fairer in Greater Manchester, I said when we launched it in June last year that it was a blueprint for levelling up. If the government was serious, we've told them what to do. We've made a whole set of recommendations. And there's a real question about how much has to happen centrally and how much can happen locally and regionally. People have pointed out that when the Federal Republic of Germany wanted to, quote, level up, in other words, incorporate the former DDR, German Democratic Republic, into Germany, they spent 2 trillion euros over 25 years, about 79 billion a year. The Chancellor has allocated £4 billion for the life of the Parliament. What? This isn't serious, mate. This is a joke. This is an absolute joke. If Germany spends 79 billion a year and we're planning, well, we don't know how long the Parliament will last, but we're planning to spend 1 or 2 billion a year. This is an absolute joke. So the centre isn't serious about levelling up. It's clear. Well, let's see what's in the white paper, but unless they're going to put real investment. So that leads to the question, how much can happen at city or regional level? And the thrust of the work that we've been doing with Greater Manchester, with Cheshire and Merseyside, with Lancashire and Cumbria, with Gateshead and other areas, is a great deal can happen locally and regionally. That, yes, there was a lot of unhappiness about high-speed rail lines being cancelled or not built in the right places. But the feedback I get from those parts of the country is not the high-speed rail lines they're looking for. They're looking for better investment in early child development and education and employment opportunities and housing. It'd be quite nice to have a high-speed rail line between Manchester and Leeds, but it'd be far more important to have these other things on the social determinants of health. I must say I was disappointed with the change from inequalities to disparities. None of us this evening has felt the need to use the term disparities. When I was getting support for my research from the US National Institutes of Health, I would put in grant applications to NIH about research on inequalities, and they would talk about disparities. And a former head of NIH, after he retired, I didn't know that he knew about the grants that his organization was giving me. And he said, I was really jealous. You were able to talk about inequalities. We were not allowed for political reasons to talk about inequalities. We had to use the word disparities. So now we've discovered how to abolish health inequalities, do it linguistically. That's not impressive.
Thanks, Michael. Jabir?
Well, it's really welcome that the health secretary is talking about health inequalities and racial health inequalities, and we should grab the opportunity with both hands. But I do fear that we need to. I do think we really need to look at the actions rather than what's being said as a demonstration of where we're going to go to. He seems to have forgotten that he's also the Secretary for Social Care, and the social care white paper has been published without the equality impact assessment being published. And there's a real question as to why that hasn't appeared when this was an expectation. So yes, good that those sound bites are out there, but whether they're actually going to be accompanied by real action is a real worry.
Great, thanks all. I'm going to jump to another question. Comes back to the discussion around the public attitudes and public awareness. The question is, one of the problems with getting the public to understand health policy is the way in which it's portrayed in popular culture. And health is too often and easily associated with clinical interventions, particularly in hospitals, which gets in the way of understanding the social determinants. So we need to get rid of Holby City and so on, just an example, I think, and think of better ways to shape the understanding of health in popular culture. Discuss. So I'm going to throw that open for discussion alongside another question, which is, where do I sign up to be a health equity rebel? Who'd like to take either or both of those? Chris, did you want to answer one or both?
Yeah, I'll take a stab. So I think being a health rebel is one of those things that you don't sign up for, but you hear the calling and you go to the streets and do it. So I think there's a kind of permission from this to go and do some of that, because more of it's needed. But on the question of health inequality, I think the clinical portrayal is a really interesting point. And I think the other thing that's quite interesting is it hasn't always been the case that we've understood health in this very narrow definition of health care. When we look back to pre-NHS health governance and how it sat within, kind of the civil service, the first Ministry of Health is really interesting because it had control for much of the poor law, for air pollution, for housing, for local authorities. A lot of the things, social security, lots of the things that we consider really important to the health inequalities conversation were within the remit of the Ministry of Health. And so we know that that's kind of been more gradually stripped away. It wasn't kind of 1948, the NHS emerges and suddenly health gets very narrowly defined. Things like social security have since been disassociated from health. And that gives us, I think, an opportunity to think about how the organisation of government and how we communicate about health can change that back as well. Because I think we can take great optimism from there having been points in history where that broad definition of health that incorporates lots of the levers that we need for health inequality were part and parcel of that package. So that's just one quick reflection, really.
Great, thank you, Chris. Richard.
I've been reflecting on this in some other context, and we were reviewing some aspects of how we, as a broad organisation and collective, had responded over this last couple of years in relation to the pandemic. And whilst, of course, this is an opportunity to publicise a King's innovation, the question, of course, is how we were able to harness the sort of socialising of health and the way in which we, a number of our investigators, developed this app. It's now known as the Zoe app, which was providing and continues to provide, in real-time data in relation to many aspects of the population's experiences of the pandemic. Now, this isn't the place for us to debate, and we certainly could, about the merits or otherwise, the quality of the data, etc. But of course, the two things that I think have come to my mind from this is this remarkable level of engagement that's been achieved. 4.5 million people continue to utilize the app. Over 800,000 people per day update data onto it. But of course, that's not uniform across all stratas of population. And part of the conversation we were having, as I said earlier today, was what innovations are there that could come into play that would have relevance to different populations and different groupings. The sign up, well, to go back to my own personal experience, as a geneticist, we developed a major program. We call it East London Genes and Health, and again, another bit of publicity that is very much focused on the populations of East London. And I personally have learned so much more about many of the dimensions that we're discussing today through the genesis of that program. So there are abundant opportunities even for rather traditional looking geneticists to suddenly find themselves thinking about the dimensions in a different way.
Great, thank you, Richard. I'm going to just run a couple of questions together now to whoever wants to answer, and then we'll come back to you for closing reflections and your thoughts on your prime ministerial policy priority. So the two questions are, thoughts on how different approaches across the four nations of the UK are impacting on either reducing or increasing inequalities. And secondly, whether there are particular areas where data is missing that could be used to help to minimize the misunderstanding of the links between social determinants and health outcomes. Michael.
Let me take the data question first. We have been blessed in the UK with high quality data, the best available anywhere. I mean, quite remarkable. In the US, they complain they don't know what's going on because of the data. I've done commissions on social determinants of health in Europe, in the Americas, in the Eastern Mediterranean, and most countries of the world can't even get disaggregated data on health. So they don't even know the magnitude of health inequalities, let alone social determinants of health. We are blessed. I pray every day somebody to protect. ONS has been so good that I'm sure the government will shut it down. They can't tolerate an institution working so well. So we've been blessed with good data. Yeah, there are bits and pieces that you'd like better. And the Race Health Observatory is very much looking at the question of getting race ethnicity as part of routine data. And that's been a big lack, It's been very difficult to get the data generally. On the question of the different parts of the UK, this is, I've asked myself this question, and it's really complicated because they don't start from the same position. So I'm doing quite a lot of work with Wales now. They have a Future Generations Act. It's really impressive. But their funding settlement largely comes from Westminster. So what they're able to do with what I would think of as their more enlightened approach to social policy is limited, A, by the huge inequalities of the starting position, and B, by the relative lack of money that they have. And Scotland's in some of the same position, deep entrenched inequalities, and not much money to deal with them. So, one of the whole debates about more devolution in Scotland is, do you want to be poorer? Do you want to have even less money than you have to deal with the issues? So it's a bit difficult to, certainly the language coming out from Scotland and Wales, it sounds a good deal more attuned to the conditions in which people are born, grow, live, work and age, a good deal more attuned to the social determinants of health. But they don't have the financial muscle to deal with these deep-seated problems. Northern Ireland, one of the legacies of Brexit, of course, is they can't keep a first minister for very long. Brexit has just ruined politics in Northern Ireland. It's a calamity. So they're in a very difficult position.
Thanks, Michael. Joe, did I see your hand up?
Only to add on the UK point that, I mean, yes, the context is different, it's hard to make comparisons, but I think what's interesting is that there are some very different policy choices being made, and essentially there's some natural experiments, and it would be good to see some money going into evaluating some of that.
Great, and very quickly, Chris, I can give you about 30 seconds.
Yeah, all I need, just on the data point, I wanted to flag as well data that's excellent but very new and needs use and refinement, I think, which is the Composite Health Index the ONS and others have been putting together. And I think as a composite measure of how health is progressing that takes in some of the socioeconomic elements of it, not just the clinical elements, it's brilliant. So I'd encourage people to use and see what's possible with some of that.
Fantastic. Thanks, Chris. Okay, I'm going to give everyone roughly 45 seconds each for their closing thoughts, if possible, including their number one priority for entering number 10 Downing Street. And let's do in reverse order. So starting with Richard, please.
Well, I don't wish to be inappropriate, but of course, the first thing I do is go and check the cellars of number 10 to see where any resources have been left for me to hold my celebratory party. But no, I think it is very simple, and Sir Michael laid it out. It can only be one priority, and we absolutely would have to place that priority on every effort, every requirement to eliminate childhood poverty, because of course that is a lifelong imposition if we don't remove that. So I have that as my primary policy.
Thanks, Richard. Jabir?
Thank you, Will. Our understanding of trying to better address racism and its impact on communities would actually ask us to do three things. Firstly, a proper social housing building program. Secondly, universal basic income. And thirdly, fixing social care.
Thank you. Chris?
Yeah, so for me, really, I think it's about the delivery mechanism that we have. And I think that free at the point of delivery based on need is fundamentally the most important and successful formula that we've come up within the welfare state as a way to meet need. And I think that the second half of the NHS project has to be expanding that to public health and social determinants of health. So for us at IPPR, that's about working out ways, public health budget being our recommendation, but working out ways in which we can allocate significant resource across Westminster departments to make sure that health need is represented in the kind of things that they're doing and the services they're providing and the infrastructure they're giving. So that would be our next step.
Great. Jo?
So just in the interest of saying something a bit different, something we haven't really touched on is the role of business. And, you know, I think we should remind ourselves that I think it's about 60% of GDP sits within the private sector. You know, we often turn to what government should do, but I think businesses on the back of the pandemic are starting to think about their role in this more. The CBI has set reducing health inequalities as one of its 5 goals, you know, which I don't think we'd have ever imagined several years ago. So I think something about the role of business as an employer, the sorts of products and services it provides, and just how it works with its local communities to tackle some of these things is an untapped area that I would prioritise.
Great, thanks, Jo. And finally to Michael.
I would look round the cabinet table and say, we were elected on a mission to build back fairer. And that means we have to put equity of health and well-being at the heart of all government policy. The way we're going to evaluate each of your department's performance is what contribution have you made to establishing equity of health and well-being. Is it possible? New Zealand's done it. They've got a well-being economy based on well-being. I'd like it to be not just well-being, but equity of well-being and equity of health and well-being.
Fantastic, a great note on which to end. Thank you, and thank you to all those who have submitted questions. I'm sorry that we couldn't answer all of them. As I mentioned at the start, this event is part of a series of talks on the Fair Society with the Fairness Foundation and the Policy Institute at King's College London. And next month's talk, which is at 5 p.m. on the 23rd of February, features Professor Selina Todd talking about social mobility, followed at 1 p.m. on the 31st of March by Baroness Minouche Shafiq at LSE talking about the social contract. Thank you to Sir Michael and all of our panelists. Thank you all for coming. I hope you enjoyed it. Thank you to the teams at King's and the Fairness Foundation, and we'll see you soon. Goodbye.
Thank you.